Can I start, madam? Vista Media, can I start?
Yes, yes, please do.
Okay, I am audible.
Yes, sir. Yes, sir.
Yeah. So good evening. Good evening. Myself Rajdeep from IPCA Laboratory. So I first of all invite our today's guest speaker and of course all invitees. And so first of all, I introduce our today's guest speaker, Dr. Siddharth Rakhe. He is a consultant endocrinologist and associate with Jupiter Hospital Indore. And sir is the director of evolution in the endocrine clinic Indore city. And this today's sir topic is diabetes and cardiovascular disease, a serious complications. So I hand over the session, Dr. Siddharth Rakhe. Sir, please over to you.
All right. So first of all, thank you for the kind words of introduction. So
It is okay.
today we will discuss diabetes and cardiovascular disease. Now, if you think about it, it's a very, beat down topic. Thousands and thousands of time it has been discussed, but still there are a few practical points when we discuss those diseases. We realize there is a aha moment that yes, we were missing that. And that's why I decided that we will discuss those. So just let me share my slides. All right. So from anyone, the cursory questions, I am audible and my slides are visible. As I said, I from anyone. Okay. So to whomsoever is listening this, let's dive into the cardiovascular disease and type 2 diabetes. So there were previous studies also, but those were associated studies. UKPDS and DCCT and the later trial proved that had the HbA1c value more the risk of microvascular complication. UKPDS follow-up data, not the UKPDS suggested that MI risk macrovascular complication also goes down with HbA1c. Yes, it showed that HbA1c high means more risk of cardiovascular disease, but it was the later on data which proved that you can reduce the cardiovascular disease with diabetes control alone. So there are multiple pathophysiological deviancies which are happening in a diabetic patient once there is a insulin resistance, so because of which extra insulin initially at least is getting produced, which is pushing the stem cells, mesenchymal stem cells, into the direction of a adipocyte. Then there is an inflammation. Higher the rate of inflammation, higher the rate of plaque rupture, which goes true for oxidative stress also, dyslipidemia also, and hypercoagulability. Now, you see, there is a very interesting fact about Framingham Heart Study or multiple other studies which said that elevated LDL is associated with increased cardiovascular mortality, but multiple trials have failed to show effect of reduced LDL intake on reduction in the cardiovascular mortality. Maybe the reason is the elevated LDL was not a causative factor, or maybe not the direct causation, but it was association because of the renal proteinuria, which renal proteinuria also results in hypercoagulability because of loss of the anticoagulant factors. Okay. So many people have tried to define obesity and the problems with obesity in different forms. Some define it by metabolic syndrome, some hypertriglyceridemia, some hypertension, and there are different treatment guidelines for all of this. For hypertriglyceridemia, initially statin plus fibrates. If your triglyceride is more than 500, it is advised. Although they have written that increased risk of pancreatitis, but now the more recent guidelines suggest that more than 50, the risk of pancreatitis is relatively higher. In diabetes, icosapent ethyl may be considered for the after statin, after triglyceride. If you still have a high risk patient, then you can use to reduce the cardiovascular mortality. For hypertension, the most important part is a low sodium diet, which no one or most of the patient ignore, and the blood pressure control should be less than 130/80. In diabetes or with albuminuria, RAS inhibitor reduce the intraclavicular pressure. may have some added advantage, but apart from that, Alahart trial suggested that it doesn't matter what kind of, antihypertensive you are using, and so far you are able to control blood pressure below 130/80, we are good to go. So what are the targets of management of CKM in diabetes? Uh, One is lifestyle modification. So lifestyle modification, there are multiple points, but the most important is if you have a obese patient, then ask the patient to reduce the weight. Obviously, stress, healthy sleep, exercise, all of are important, but the quantum of improvement comes, which we can achieve with weight reduction is the maximum. And second, I would say smoking. Then you have to define a target for your particular patient. Young patient, tighter HbA1c, tighter blood control. Older the patient, you can be little liberal. Then you have your LDL data. We have to reduce the LDL by 50% by either with statin alone or ezetimibe, as improve it trial has showed that if you add ezetimibe, even if it is LDL is within target, you can have a reduction in the cardiovascular mortality. Then we have the newer generations of anti-diabetic drugs, in which we have SGLT2 inhibitor plus GLP-1 agonist, which have not only anti-hyperglycemic effect but also cardiovascular protection. So this is roughly the algorithm. If you have hypertriglyceridemia, the most important thing is lifestyle modification. Whenever a person sees elevated triglyceride, the pen jumps to a fibrate. But if you think about most of the guideline in diabetes and dyslipidemia, the first treatment or the first drug we should start is statin to reduce the cardiovascular mortality. And if TG is more than 500, then you add fibrate. If you have 135 to 429 of fibrate, try to control the diabetes and obesity. Adding fibrate, doesn't give you that much of a cardiovascular protection than improving the lifestyle. Hypertension, first of all, low sodium diet. We have read it so many times: Falani diet, Nimka diet, Mediterranean diet, Dash diet. Every diet was low on sodium, and if you quantify the sodium intake of Indian diabetic patients, it's way above the recommended. And if you are able to reduce then it's good. If you have albuminuria, you should go ahead with ACE ARBs. If without albuminuria, it doesn't matter which antihypertensive you are using. If you think your patient is at high risk of CKD, then apart from ACE inhibitors, SGLT2 inhibitors plus ACE ARB plus Finerenone can be used, but obviously we have to be very cautious in the starting to look for the side AKI. And for diabetes, there is lifestyle modification, moderate to high intensity statin. For your high risk patient, you can add ezetimibe. So this is one point which we should understand, that if you have a patient who says कि भाई मैं तो smoking भी नहीं करता, HbA1c भी मेरा पौने 7 आ गया है, बीपी भी ठीक है, what else can we do? और मेरे को 3 बार छल्ला डल गया जी. What else can you do? You can add one thing as ezetimibe. If your patient is obese, you can add a GLP-1 receptor agonist. है ना? I mean, these are the things in which we can with which we can reduce the further risk of cardiovascular complication. Now, there is a second important point on this slide only, that many a times, see, typical the guideline says that if you have a type 2 diabetic patient, start with metformin, no questions asked. But many guidelines are now pivoting toward earlier adaptation of these newer molecules, be it SGLT2 inhibitor, be it GLP-1 agonist. Because if you have a patient with HbA1c even 7, 7.2, and you think that some CV risk in form of family history, smoking, or some other family risk is there, then cardioprotective antihyperglycemic agents may be started with metformin, because at the same time you are getting good glycemic control and reduction in the cardiovascular complication. See, nowadays CT coronary angiography is being commonly used to stage the risk of cardiovascular disease in the CKM syndrome. And there are multiple parameters we can deduce from CT coronary angiography, but the most importantly and widely acknowledged is coronary calcium score. Higher the coronary calcium score, it means there are calcified plaques. Now, there is an interesting thing about CT coronary angio. It can identify the calcified plaques, which can result in SIHD, which is stable ischemic heart disease. But these are the plaques which are calcified. So you see, the plaque which ruptures, the plaque which gives a patient ACS or the thrombotic risk, are not heavily calcified plaque, but it's a raw plaque with a thin cap, thick, accumulation of a triglyceride or a lipid-rich core. But nevertheless, if you have coronary calcium score above 100, then you have a patient who is at coronary, because ultimately it is a calcified plaque, which is a dystrophic calcification, which means that there was some inflammation which has not calcified. So obviously some coronary artery disease is present, and we have to add SGLT2 inhibitor and the other uh, uh, drugs which we can use to reduce the cardiovascular mortality. So if this is in those patient in which there is no existing cardiovascular disease, now you have a patient uh, with existing cardiovascular disease, then apart from your obvious this thing, managing blood sugar, managing blood pressure, managing weight, reducing weight, control of dyslipidemia, you have to screen for other parameters, and you have to titrate your whatever treatment you're giving, be ACE inhibitors with SGLT2 inhibitor, to the GDMT, which is a guideline directed medical therapy. So always, keep a watch whether the patient can be increased some beta blocker in a heart failure patient, can be increased ACRBs to give maximum protection, cardiovascular protection. Many times a patient is on 40 milligram telmisartan, he's still on 40 milligram telmisartan, and the potassium is 4.1, 3.9, and the hypertension is allowing you. So in those patients, be more active, add more, GDMT, so that you can reduce the cardiovascular risk. So these are the rough guidelines of how to manage the other components of the CKM stage 4. We have covered the hypertriglyceridemia, that fiber rates more than 500. Higher risk, you can add EPA. Hypertension, again, same. In this non-steroidal steroidal mineralocorticoid agonist, previously AHA guideline used to say that any patient with reduced EF, you should add a aldactone to have the and organ protection effect. For CKD reduction, again ACRBs for urine ACR, increase for elevated urine ACR, ARNI for heart failure with reduced ejection fraction. And if you have residual albuminuria, you have to add a non-steroidal mineralocorticoid antagonist, which is Finrenon. Now this Finrenon is, making itself as it is space in heart failure with preserved ejection fraction and reduced ejection fraction as well. For diabetes, to reduce MACE, SGLT2 inhibitor or GLP. To reduce heart failure hospitalization, SGLT2 inhibitor. This is an important point. You have a patient who says कि मेरी सांस फूलना तो बंद ही नहीं हो रही है, 3 महीने में 2 बार भर्ती हो गया हूँ. So those are the kind of patients in which SGLT2 inhibitor would work much better than GLP-1 agonist. You see, cardiovascular protection, yes, both are good, but this particular subset SGLT2 inhibitor is a better subclass of drug. This we have already covered. A few points about SGLT2 inhibitor. Just now I said that there is a subset of patients who is experiencing dyspnea, and SGLT2 inhibitors are very good drug because they inhibit the SGLT2 channels located in the renal proximal tubules, thereby causing glycosuria. When they cause glycosuria, along with it, there is some diuresis and some natriuresis is present, and there is something called as TG feedback. I don't think they have written it here, but there is something called as tubuloglomerular feedback, which causes some reduction in the blood pressure, some reduction in the preload and the afterload, and it is associated with some degree of weight loss. We will see there are some trials which said that even more weight loss can be associated depending upon the geographical area the study is being done. And this here, increased ketone bodies. So in this, see, ketones body can be produced in type 1 diabetics also, and ketones bodies can be produced with SGLT2 inhibitor also. But depending upon the other metabolic condition, the same ketone bodies may be beneficial, the same ketone body may be harmful. So this is the chart I was talking about, in which depending upon the trial data, we may have a substantial weight loss. So if you see in kgs body weight loss, most of the trial are associated with some degree of body weight loss. Few trials suggest there up to 2 to 3 kg of body weight loss can be associated with the SGLT2 inhibitor when you add it as an anti-diabetic therapy. Obviously, some of it is natriuresis and a diuresis part, but nevertheless, some fat loss is also associated, and motamati is associated with reduction in HbA1c, fasting plasma glucose, systolic blood pressure, and by reducing these points, it results in reducing cardiovascular mortality. So declared TIMI 58 was, so declared TIMI, basically this is a thrombolysis in myocardial infarction. Multiple trials with TIMI, different number has been done with a different number related to them. This was declared TIMI 58, which was done for dapagliflozin, roughly 17,000 patient at high risk of CV event. And they were followed for 4.2 years, and the trial was dapagliflozin versus placebo. And we see this forest plot here, and the hazard ratio is mostly in favor of dapagliflozin, with death from non-cardiovascular cause being the best parameters in which improvement is there. In some parameters, ischemic stroke and death from cardiovascular cause, the standard coefficient of variation CV confidence interval goes on the either side, but nevertheless, for majority of patient, we can say that there is a substantial reduction in MACE, cardiovascular death, or other parameters which we use to measure the CV risk reduction. The other trial was DAPA-HF trial, roughly 4,000 patient with NYHA 2 to 4 were enrolled and followed up for 18 months. And the data suggested that the CV death or hospitalization reduced by 0.83. Hospitalization, if you see, reduced by 0.73, which is, again, what I said is, is a subset in which dapagliflozin or the gliflozin is better than GLP-1 agonist, and the worsening of heart failure and CV risk death was also went down. Few points about DPP-4 inhibitors. Now, DPP-4 inhibitors, they act by increasing GLP and GIP, thereby have minimal effect or mild effect on the pancreas insulin secretion and decreasing glucagon, and they improve hypertriglyceridemia. They have weight neutrality. But when it comes to cardiovascular mortality reduction, they are neutral. There is no, in fact, there was one trial with one of the molecule in which there was some increased in the cardiovascular mortality, especially heart failure. If I remember correctly, heart failure mortality was higher. But when it comes to sitagliptin, the TACOS trial suggested that motamoti it is safe. There was no increase in the major adverse outcome. In this, roughly 14,000 patient was followed for 3 years, and there was no increase in the cardiovascular mortality. I think it was gliptin in which there was an increase mortality. So I think that is it from my side. See, if anyone was paying attention, important points. One was about improve it trial and ezetimibe. If you have a high risk patient, add ezetimibe, you can reduce the cardiovascular mortality. Second point, if you have a patient
ये
with
यहाँ म्यूट है ना अपना ये यहाँ लिखा हुआ कोने पे म्यूट
नहीं जी म्यूट नहीं है आपका. The second subset of the patient in which which may derive some benefit are with dyspnea, which may feel better with SGLT2 inhibitor. So I think that is it from my side. If there are any questions, then I would be happy to answer that. I doubt there will be any. All right. If there are no more questions, then I will say a very good night. I take it that as a yes. Bye.
Hello. 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 Sir. Hello. Hello.
हेलो हेलो
हेलो हाँ रोहित. हेलो
हाँ सर
सर. सर गए क्या? हेलो.
हाँ गए सर।
अच्छा गए क्या? चलो थैंक यू। अरे यार सर,
ठीक।
ठीक है थैंक यू
जय श्री
अलख निरंजन।
हो गया ना खेल खत्म। वो तो हमने मतलब किया है ये हमने किया।
हेलो। चलो ठीक है, लगा दो
इधर ना बात करो जल्दी बात करो। शायद कैमरा सामने हो। कैमरा तो नहीं
Do we need to end the session?